Just give it a little while. It's still trying to build to come up soon. Okay, we are up live on Doctors Global Conference. Guests should go and share it on their screen. While we wait for guests to share it on their screen, we just give them a little 3-4 minutes to go share it on their own pages, and all for the guests to be ready for us. We'll be talking health topic today. So just give our guests a little 2 minutes to share it on your live face. I can see it on my live screen. Give them 1, 2, 3 minutes to share it on your live feed. Okay, thank you. So you can guests can also send us private messages if they're having technical difficulties. Our technical team should be able to take care of that. Guests could also log in and share it on their live feeds. If they're having technical difficulties, they should let us know. Please ensure all guests should ensure that it is on their screen, and we should be starting in the next 20 seconds. All guests should ensure it is on their screen. We should be starting properly in the next 20 seconds. We're having some delay in transmission, but we should be up in 20 seconds. We're having some transmission in delay, but we should be up in 20 seconds. We're having some transmission in delay, but we should be up in 20 seconds.
WhatsApp message. Where did the message come from?
I will also share it on my own personal wall so that people can share. I'm going to share it on my own wall so that people can also join me. So I'm going to share it on my own personal wall. Share an event. Okay. So if someone has shared it, please tag your friends. It should be up in 20 seconds. Okay, we're still doing the share button, waiting for all the guests to share on their personal pages. All right. We should be starting in 5, 6. All guests, please unmute yourself. We're live on Facebook. Welcome today to Doctors Global Conference. Doctor Global Conference is where professionals and experts from various medical fields meet and we discuss medicine. We're trying to make sense out of the various data that is going on around the world. It's lovely. It's nice. We had a lot of feedback in the last time, and we hope to get feedbacks this time around. Send us your questions. Send us private chats. Send us messages. The aim of the program is to educate the masses as much as we can to ensure that we do our own part to reduce this scourge. Today with us, we have a live coronavirus survivor. Her name is Miss Rena Roberts. It's a pleasure to have you with us. We have various experts from various fields. I'll begin to mention them one after the other. Dr. Theophilus is from Canada. Dr. Theophilus is a public health expert from University of Derby, did his public health in University of Derby, is a medical doctor, a health promoter, a public health professional. We also have Dr. Ovie. Dr. Ovie is a health economy specialist who specializes in revamping healthcare. For those that are joining us for the first time, we have a previous guests that are with us here. Those previous guests are Dr. Egbe Efefa. Dr. Egbe Efefa is a general practitioner from United Kingdom. Dr. Egbe Efefa she's a general practitioner from United Kingdom. She'll be joining us live. We also have other guests, a new guest that just joined us, Dr. John. Dr. John is a pathologist, a forensic pathologist. So he'll be telling us what they see when these patients die, not only when patients die, what the pathologists have been saying. We also have Dr. Joseph. Dr. Joseph Okegwale is a public health, no, not a public health, he's an obstetric and gynecologist specialist, a consultant. He's from Nigeria, very renowned personality from Nigeria. We have also in our midst, Dr. Omar, for those that joined us before. Dr. Omar is a radiologist, a specialist radiologist, consultant for University of Benin Teaching Hospital. She's a radiologist. Dr. OJ is joining us from New York once again. He has managed a lot of cases. He's a specialist in internal medicine. He has seen over 600 coronavirus cases, and he'll be joining us talking from the field experience. Also with us today, you could see we have a lot of experts. Everybody wants to make sure that the world is on the same page. He's a pediatrician, a pediatric surgeon, actually. Pediatric surgeon, Dr. Victor Emodi. Dr. Victor Emodi is a pediatric surgeon in Cambridge, UK. I hope I'm right. Yeah. He's a pediatric surgeon from Cambridge, UK. He'll be talking about the pediatric population, trying to make sense of what is going on in the pediatric population. We have Dr. Ben Orinami. Dr. Ben Orinami is joining us from Canada. He's an ear, nose, and throat specialist also. We know there's a lot concerning ear, nose, and throat about in this particular issue. We have Dr. Francis. Dr. Francis is joining us from US, Maryland, US. Dr. Francis is a research specialist. He's done on countless number of clinical researches, and he'll be talking from a clinical research perspective. We have so many other people. This is for those who want to have a closer view of Mrs. Rena Robert. This is Mrs. Rena Robert. She went through the valley of shadow of death, survived this coronavirus problem, and she's going to be telling us so much about her personal experience. But before we do that, we had a lot of feedbacks from the last time. Someone, Mrs. Maila, sent us a video from South Africa, and she's going to tell us what she feels about the program, about coronavirus. Kindly listen to her. Thank you.
Hello, Doctors Global Conference. My name is Bridget Maila from South Africa, and my honest opinion about COVID-19 is that it's a deadly disease. that has no nuclear weapons but is constantly taking the lives of many around the world. What I know
So
about
we're having
it
some
is
technical
that
difficulties with
it spread from
Bridget
person to
Mela. We'll play
person,
that tape
and the spread is more
again,
likely
what
when
she
people are
sent
in
to
close
us, and we'll play it again when the time comes. We're going straight to the topics. Dr. Theophilus, he will be telling us first about, it started in Wuhan, the problem, now it's all over the world. Trying to find Dr. Theophilus. We started in Wuhan, now it's all over the world. Dr. Theophilus, what can you tell us? When they say community spread, what do you mean by community spread?
Hello, can you hear me?
Over to you, Dr. Theophilus. Very well.
Okay, thank you very much for having me in this forum today. Before I go ahead to answer your question, I want to first of all congratulate and thank you, Dr. Edward Sokobi, for having the courage to convene, to organize this forum. Last week was very educative. I watched you guys last week from the beginning, and I had enjoyed myself. I want to also congratulate the panelists, despite those who were here last Sunday. You guys did a great job. All right, so thank you again for having me. Community spread, as the name implies, in the simplest of terms, in the layman's way, is the spread of a contagious disease within the community. But specifically, by definition, community spread is the spread of a contagious disease, in this case, COVID-19, to individuals in a particular geographic location. There are two things we must take note in the definition. Individuals in a geographic location, and then those who have not had a contact with people who are infected with the disease. So community spread, in a particular location, these people have not had any contact with someone who is infected with the virus, and also they've not been to a location that has documented cases of COVID-19. That is community spread, and that is why it is something that is of concern in public health. There is a renowned doctor in the US known as Dr. Anthony Fauci. I'm sure a lot of you know who Dr. Anthony Fauci is. He's a specialist, and he's an expert in coronavirus in the US, and he works closely with the government of the United States. He said that because of community spread, it is difficult to predict how far this disease can go, because people are having the condition. They cannot tell the doctor how they got it. They can't say they had a contact with someone who had the virus, and then but they come down with the disease. So community spread is something that is very important. That is why there are public health guidelines, and that is why the emphasis on prevention, we talk about prevention. It cannot be overemphasized when it comes to coronavirus. Thank you. Do you want to go further to talk about transmission and all of that?
Well, that's very educative. That's very educative. Just tell us a little bit, when you say community transmission. So how do I, living in the streets of Ghana, how do I get it? How do I get living in the streets of Liberia? How do I acquire it? A lot of people are there, just wondering. Okay. Oh, it's a white man's disease. It's not going to get to us.
All right. Thank you very much. Okay. So that takes us to transmission. Now that we know what community spread is, we can now go ahead and talk about transmission of this disease. Now, before we talk about transmission, let me first of all establish some facts. That because COVID-19 is a very novel disease, and it's the epidemiology, the the transmission, even the mode of transmission is still being studied. The conversation around this disease is based on four things. One is based on currently available scientific evidence. The other thing that that helps to have this conversation are based on public, expert opinion from experts. So we take their opinion and we work with it. And then there's also public health recommendations, as well as the fourth one is using historical data to talk about COVID-19, because you have to look at what pandemics have happened before, and then you can use that to guide your information on how you tackle this disease. So transmission, in talking about transmission of COVID-19, we must establish that, according to the World Health Organization, symptomatic cases of COVID-19 is the major cause of transmission. That, in other words, people who have, the virus are majorly the ones spreading the disease. Even though when this virus started in Wuhan, China in December last year, there was the general opinion that it came from a particular, animal host. And it's still believed today that that is how it started, even though there is no documented evidence to prove that was how it started. But even though that is believed, this virus has since changed and upgraded itself to spread from human to human. So you cannot convincingly, you can say, convincingly that this virus was exported from China to other parts of the world. So that is why it is of concern that this virus is spreading from human to human. So symptomatic cases, according to World Health Organization, on March the 8th, 2020, that this is the major driver of transmission. However, many people with COVID-19 have only mild symptoms, especially at the early stage, and they can also spread to, this virus to other people. That's the first thing. The second thing I want to say about transmission is that asymptomatic and pre-symptomatic transmission is also possible. Asymptomatic are those who don't have symptoms. And then pre-symptomatic is those who have the virus, but they are not manifesting yet. So before they manifest, they have the ability to still spread this virus. And that is, again, very worrisome. And there is evidence to this. As a matter of fact, there are over 10 studies that have been carried out since this COVID-19 pandemic to show that pre-symptomatic transmission is very possible.
Do you have the evidence?
Yes, I'm going to show us a study. Let me see if I can share my screen. There is a study that was done, that was recently published. It was published in April. That was last month. 1 second, let me share my screen.
No, just take your time. While we're waiting for him to share his screen, Dr. Francis will be talking to us next.
Hello, can you hear me?
Very well. Absolutely.
Your voice is faint, Dr. Edward. I don't know if the other people can hear me clearly.
Yeah, I can hear you very well. We can all hear you.
Okay, great. So I'll continue. Now, this study, as you can see on the screen, was published on the 15th of April, just last month, in a peer-reviewed journal. There is a journal called Nature. It's actually a British multidisciplinary journal. It's a scientific journal, and it's been there since 1869. It's actually one of the most recognized scientific journals in the world. As a matter of fact, in 2018, Nature journal they won the most cited scientific journal in the world. So this study was published. It was done by some Chinese researchers. It was published on the 15th of April 2020. And what they studied was they studied 94 patients who have laboratory diagnosis of COVID-19, and they were admitted into one of the hospitals in China, in Wuhan, China. They call it Guangzhou 8 Hospital, 8 People's Hospital. So what they did was they were trying to look at the viral load, the viral shedding in these patients. So what they did was to take throat swabs from this patient. They took throat swabs from these patients, and then they began to see the changes in the viral load from the time these patients presented until they could no longer detect the viral load. That was on the 21st day. So they took over 400 throat swabs from these patients. Apart from that, they also molded another pair, about 77 pairs of, they call it infector-infectee pair. That is, one person, like A, infects B. So they modeled that, and what they were able to, so what they are trying to do from this study is to see if the patient, if patients, before they present with their first symptom, if they are most infectious before they present. And they found out that the viral loads were highest just about the time they presented with the first symptom. It's interesting. So they were able to infer eventually that 2 to 3 days before patients present with their first symptom, those who actually have the disease, they are most infectious 2 to 3 days before their first symptom. And this was also in line with other studies that, about 2 other studies that were done in China, and also had some correlation with some, World Health Organization guidelines. This is just one of the studies, but there are other studies that were done to show that patients may be most infectious before their first symptom. And that is a source of worry to, public health experts. Now, the only thing is that even though they may be most infectious, pre-symptomatically, it is not clear if this is the major driver of transmission. So World Health Organization says those who are symptomatic, they think they are the major drivers. This study also says these people are, can transmit infection, but we don't know which one is the major driver. But what is known is that transmission is possible in these 2 instances. That is why prevention cannot be overemphasized. People have to maintain, follow public health guidelines on preventing, getting the virus in the first place. And also, what these guys, after they did their study, they now recommended that contact tracing is very important. Contact tracing. So if people come down with, the virus, you have to do contact tracing of those they had contact with quickly, because even though they did not present with symptoms before they had contact, they could actually still, have given them the virus.
Right.
And this will help us to do what we call flattening the curve. And I will show us something later on in the conversation, what flattening, what it means to say flatten the curve of the spread of COVID-19.
Thank you so much, Dr. Theophilus. Thank you so much. You've actually, can you end the screen sharing and return the functions back to me? You've actually said some very meaningful
For
things.
some reasons, I can't hear you clearly, Dr. Edward.
Okay, just end your screen sharing and return it to me. Just end your screen sharing and return the screen to me. Thank you so much. Thank you so much. You've actually said so much. Can you hear me clearly now? Can everybody hear me? I want to be sure the audience can hear me. Dr. Ovie, can you hear me?
Yeah, I can hear you.
Yes,
Yeah,
I can.
but I wasn't done with talking about transmission, but maybe you want to continue, then later I'll continue where I stopped on transmission.
So, yeah, we're going to get back to transmission because it's very important that people know what it is to transmit this disease to other people. But before we talk about transmission, we have someone in our midst. Mrs. Rina, you've had this COVID virus, you've survived. Can you just, in probably 2 minutes, just tell us, did you ever think you would get it? I'll put you on the screen, I'll pin you on the screen. Did you ever think it's something you're gonna get?
No, I did not think so.
Wow, when did you find out? How did you know?
Can you hear me?
Yeah, very well.
Okay, so thank you, first of all, for having me. And to answer your question, I did not think so. I personally took every necessary preventive measure. I was abiding by the rules. I was still working, obviously, but I did not know that I was going to be hit. But at the same time, I had my mind open, like anything can happen because I work in the health field as well. So I was just open in my mind, to it, but I did not have that in my, I wasn't expecting it as well. But then the thing is, when I was hit, on that day, on the 8th of April, when I felt the pain, I didn't even think that way. I was just thinking it was my heart just, hurting me, and my mind did not even cross to COVID, COVID-19. I was just thinking maybe it's
What
just
were the
my heart.
symptoms you had that made you think?
Yeah, because the symptom was just ache. Yeah, it was like heartache or pain in my chest. That's how I felt that morning. So I was like, I just brushed it, brushed it over and like, yeah, I'm gonna be fine in a couple of minutes. Maybe, I'm just kind of worried about homework or something. So I'm trying to focus, and I was at work, and this pain kept coming every now and then. This sharp pain would just run through, and so my coworker told me to just go and get checked up. So that's how I was able to go and get checked up. Do you want me to go further, or you said 2 minutes? I'm checking the time. That's fine.
Yeah, you don't have to check the time. I mean, people want to know what's going on. People want to know how do they feel.
So
People want to know, were you scared? Do you think you would die? What happened?
then I started feeling the tingling in my throat. So when I started feeling like I'm about to get cough or something, I'm like, what's that? Kind of tingling in my throat. So then when my coworker, like I said, encouraged me, I spoke with my bosses and they said, you can go. I left. I went to the emergency and I was afraid. When I got there, first thing is I'm seeing this tent in front of the emergency, the entrance. And I'm like, if I don't have, if I go in there, I don't have COVID, I'm not out, so I could contact this virus by just passing through those people. So I spoke with the emergency online service, and they said, "Oh, this it's an empty tent, so come in, you're welcome." When I went in, I told them I'm just, just a little pain in my heart, but other than that, I think I'm fine. And then I mentioned that later on that I have this tingling in my throat. So the doctor said, "Okay." So they ran the EKG, they did my blood work. They also did checks the chest x-ray, and then when they did those, then she came back to me like after like an hour or so, and the doctor, she said, ma'am, we're gonna recommend that you do the COVID test. So I said no problem, because I was kind of like, hey, nobody around me got this thing. I don't know where. I've been going to work, and I've been, in a store regularly, not regularly, but every now and then going to get some groceries for my family. And we've been careful. I come home, I do what I got to do with myself to stay away from my kids, to do, and take care of myself. So my mind wasn't on it. But however, when she gave me the prescription, I drove to the site, and I got the test, and it told me to just
Wow.
quarantine myself until my results can come.
Wow. It seems we're
Because
having
they were a
a
little
little
bit
bit of.
backed up.
Yeah, go ahead.
They were a little bit backed up, she said. So it's gonna be, your results gonna come in like 7 days or maybe even more. However, it came in 6 days. When it came in, it told me I was positive. I was shocked. And moreover, I was praying to like, God, who would want to have that? Like, God, this thing is deadly from what we're seeing right now. I don't want to be tested positive. So I was like, hey, Father, you got to do something for me, help me. But at the end of the day, when the result came, I was positive. And I took it, I embraced it. I just started to take care of myself going forward and take care of my family as well.
Oh, wow. That's so interesting. We'll come back to you, Miss Rena. We're going straight to questions from the audience. While we're waiting for those questions, there are so many questions the audience asked the last time. We're going to be taking them. We know that the medical world in general has been, pushing to find treatment, the definitive treatment. Right now, there's a palliative treatment that Dr. OJ is going to talk about, but there's a futuristic treatment, what we call research, what the medical world is looking at. Dr. Francis, can you share a little bit from your research experience what the world is looking at? Because right now people think it's vaccine. There could be other things. What are they?
Thank you so very much, Dr. Edward, and thank you for having me. It's always a pleasure to be on this platform. I also want to thank all our presenters for being here on the Doctors Global Conference. Last time we had a very interesting and interactive session. Today, I'm going to be continuing on what I started last week on the clinical trial efforts, what we're doing. And what I'm going to do at this point is to share my screen very quickly. I understand that we're time constrained, so I'm going to try to not spend a lot of time on my presentation. And everyone see see my screen? Can you all see my screen?
Yeah, we can see your screen. Go ahead.
Okay. All right. So, the COVID-19 continues. It's a worldwide pandemic with a significant public health and economic burden, like we know. There are no current approved treatments or any strategies for managing this disease. But let's just look at the background. We know that back in 2012, there was the MERS, coronavirus or COV that was found in Saudi Arabia. And again in 2003, was the SARS-CoV was now discovered. Now, coming back to 2019, we all have heard of the COVID-19, which is basically what stands for coronavirus disease 2019. Before 2020, the largest outbreak was of SARS-CoV in 2003. I'm not going to read this slide for you, but it's interesting to see. I'm not going to talk on the viral particle. I'm going to leave this for a virologist, whom we hope to have in the course of this presentation. But if you look at this slide, which I called from the National Institute of Allergy and Infectious Disease, we can see how these are the yellow particles are the virus, actually, the viral particles, and this very large one is the apoptotic cell, heavily infected with the SARS-CoV. So this is an electron micrograph of how it looks like. Pretty interesting. But backing up to what we have currently in terms of the clinical trial interventions, there are, you mentioned vaccine. Vaccine is just one component or one element of what entails in clinical trials. There are quite a number of agents that are being explored, are being tested out there. And I'm going to start with the antivirals. The reason for this is because obviously this is a viral infection. It's a viral organism. It's a virus. So, antiviral, there are quite a number of antivirals that are out there that are being tested currently. But one of them, which is pretty interesting, is remdesivir. Remdesivir was given what I call an emergency approval by the FDA, the Food and Drug Administration and Control here in the United States, FDA. What they saw was that preliminary results indicates that patients who received this antiviral agent had a 31% faster time to recover than those who received placebo, which is just an agent that does not have any active ingredient inside. So that's where we are right now. The remdesivir is an antiviral drug that was developed by Gilead, as a pharmaceutical company, in 2014. And they developed this drug for Ebola treatment. We all have heard of Ebola back then. It's a nucleotide analog, specifically an adenosine analog. Evidence to have broad spectrum activity against the single-stranded RNA viruses. I'm not going to go again reading all of this slide, but very interesting to know that just recently, like I said, the US Food and Drug Administration issued an emergency use. And what does it really mean for emergency use? Emergency use authorization for this investigational drug, remdesivir. It means that it can be used for the treatment of suspected or laboratory confirmed COVID-19 in adults and children hospitalized with severe disease. Again, there's limited information about the safety and effectiveness. Remember that clinical trials are mostly geared towards, safety and efficacy data. So those data is what we work with. If there's any statistical evidence that these drugs work, we want to look at the safety and efficacy before we go to the market. So that is where we are. So again, this drug, people are excited about it, but it hasn't gotten a general approval to go to the market yet. But we are looking at getting something that we can use to reduce the scourge of this very, very, terrible.
Thank you so much.
Before let me just quickly go through a couple of other things. Now, there are people have talked about anti-malaria, chloroquine, hydroxychloroquine, and azithromycin. These agents are still being tested. In 2002, an outbreak of SARS virus caused a lot of deaths in Asia. And they found that chloroquine can reduce or resulted in a significant decrease in the replication of this virus. So they're looking at, hey, is it possible that chloroquine can find efficacy in treating this scourge? So anti-malarials have been tested. Now, other things, very quickly, I'm not going to go through this, but other things that are currently being looked at is what they call plasma therapy. Plasma therapy. They are thinking that if they harvest the plasma from patients that have survived this virus, there might be a chance that the plasma will contain antibodies that will confer some sort of immunity on the recipient, those that are having active disease. So they're looking to harvest the convalescent plasma, and introduce it or give it to those that have active disease. Again, let me just very quickly share a slide before I leave. Now, this is a slide. Again, these are all out there in the public domain, and I got all this information from established registries, clinicaltrials.gov. There are a number of clinical trials, as you can see. This is a list of quite a lot of clinical trials that are going on. These are active treatments, and they are still being tested, not approved to go to the market. Quite a number of them. So, finding the treatment continues. It might take some time. Like I mentioned before, clinical trials are expensive. The pharma companies are really skeptical in terms of investing their money in finding a cure, but they believe that it's worth all the while. So you can see the list of,
wow, there's a lot going on.
Yeah, there's a myriad of trials in China, obviously, because that's where those virus first originated, and all over the world. Quite a number of them. You can see that they are all recruiting, and these are the agents, and these are the registry number that one can access in public domain. Well, so we're going to keep looking at this, and hopefully we'll get the treatment or a vaccine for COVID-19.
Thank you so much. Thank you so much for this. We're going to come back to you because a lot of people want to know what trial actually means. What do you mean by trial? There's something going on in Madagascar. There's something they announced in AWU. People are bringing up herbs. We'll also ask Mrs. Roberts what she used, but we'll come back to you when we get there. We're going to take a little 1 second break because people are complaining that they can't see it on our wall. Please go back to your Facebook wall and verify if you can see the live feeds for the guest speakers. Please recheck if the live feeds is on your wall. We're going to just give 1 minute for people to re-verify the live feeds to be sure that their audience are following them, because there's no need for us to be talking and people can't, follow us. So if it's on your Facebook wall, we'll just take questions from the audience and we'll go from there. Dr. Theophilus, is it on your wall?
Yes, I can see it on my wall, and some of my friends are watching.
Oh, okay, that's beautiful. Dr. OJ, can you verify that on your own wall?
Yeah, it's on my wall.
Okay, good. All right, good. So we can return back to what we're saying. I can't, for some reason, I can't find it on my own wall. Okay, so someone just verified that it's on my wall. So we're good to go. We'll go back, we'll dive deep. We're going to dive deeper, but before we dive deeper, let us quickly listen to what our friend from South Africa, she said she's been listening to us and she wants to tell the world what she thinks. So we'll just listen to her for 2 seconds.
Hello, Doctors Global Conference. My name is Bridget Maila from South Africa, and my honest opinion about COVID-19 is that it's a deadly disease that has no nuclear weapons, but is constantly taking the lives of many around the world. What I know about it is that it spreads from person to person, and the spread is more likely when people are in close contact with one another. What I don't know is how long it will take for the disease to be eradicated, how long it will be until they find a cure to this disease. And my concern is if measures are not put in place, it will continue to spread and it will continue to cause harm and damage around the world. I do not think I'm at risk because I am practicing safety measures. My concern is about people that are around me that do not have gloves, that cannot afford sanitizers and do not have masks. What about their safety? People are not taking it well in my country. They're in fear. They do not want to go out, regardless of the lockdown. They're afraid that they might be the victim to this virus because it's spreading every day and it's spreading rapidly. How it's affecting life in my country is that movement is ceased, people aren't able to go to work, and so if they do not work, they cannot get paid, and so they cannot feed their families. Students are also affected by this pandemic because they're not able to go to school because movement is ceased. And what I can add is that now the only thing that we look forward to or that we prepare ourselves to hear is the update about COVID-19, how many people have been affected, how many people have unfortunately lost their lives.
Thank you so much. Thank you so much. Thank you
Hello,
so much.
Dr.
Thank you so much
Bridget
for
Maila
that
Africa.
presentation. We'll continue with our question line if you heard what she said, that she doesn't think she's at risk. Dr. Egbe, can you hear me from UK?
Yes, I can.
Yeah, if you hear what she said she doesn't think she's at risk. I'll let you and Dr. Theophilus, before we go to the other specialists, we'll go around to everybody. So many people don't think they are risks, and you see people floating this stay-at-home order. Dr. Theophilus, quickly, why do you think people think so? And do you think it's wise to continue listening to the government, the stay-at-home order?
Okay, thank you again very much. I was going to talk about person-to-person transmission, which is mostly occurring, through respiratory, infectious respiratory, droplets. What this means is that people, when they cough or sneeze, they release large respiratory droplets that has the virus in it. Now, if you are in close contact with such a person and you are not aware that this person has the virus and you are not wearing a mask, so this virus can enter the mucous membrane through the eyes, through the nose, and through the mouth. And when they sneeze and release this cough and release these droplets, then this virus can have access to any of your mucous membranes. That is why we are told to keep safe distance, physical distance from people, and wear protective equipment. So some people can wear goggles on their eyes, they also wear face masks to prevent that. Also, this virus can be on surfaces. It can be on your phone, on your tablets, on your laptop, on your clothes, on the door of your car. When this, when people release these droplets and they are there, and then you touch it with your hands and you touch your face. That's why you are told to avoid touching your face with your hands, and also to wash your hands regularly. So when you touch these surfaces, you have to wash your hands. Everybody is at risk because, like I said before, you don't know who has the virus, because people can actually, have this, transmit this virus through, even when they don't have symptoms. That is for the person-to-person transmission. There's also according to the CDC, that the longer exposure time and those who have severe illness with coughing are at high risk of having, this virus. So if you stay in an environment where, longer than expected, you can put yourself at risk. And if somebody is already having a cough for a long time, and that's a cough, the person is also at higher. That's according to CDC. Then the issue of airborne transmission has not been documented. So WHO has already ruled that out. So there is no airborne transmission.
Wow, that's really cool. You talked about person-to-person transmission, Dr. Egbe. The use of face masks is one of those things that we use to prevent. Many people are wondering, cloth face masks, these face masks, is it going to work? Can you talk about it a little bit? You're mute.
Can you hear me now?
Yeah, I can hear you.
Right. See, our last speaker has spoken very well about transmission. So can you hear me clearly?
Yeah, very well.
Okay. I'm sorry, I just forgot to say thanks for having me again. So face masks, he mentioned personal protective equipment. And he mentioned other things that we can do to help ourselves. He talked about social distancing, which is extremely important. He talked about washing, he talked about it being on surfaces, and that's why there's emphasis on washing the hands. But he also mentioned face masks as well. So in terms of face masks, there are different kinds of face masks. Face masks are part of the things that people can wear. There's still, the jury is out there. There's little evidence that it protects the wearer from catching the virus. But what's more important is preventing someone who may be pre-symptomatic, as he said, when you might be spreading the virus even a few days before you develop symptoms. So even if you are not aware and you are going to come down with symptoms, it stops you from spreading it to other people close to you. Now, because of that and the small risk of asymptomatic transmission, and the fact that there's places where, for instance, in supermarkets, people might find that kind of 6 feet, the distance recommendations difficult to keep. It's important, it's imperative. That's why they are recommending that face masks be worn in public. Now, I think the evidence has changed a little bit. Initially, it was being said that there's no real need to do that in the community as widespread wearing of masks. But now a lot of countries are changing that and saying, well, it's better everybody wears a mask. There was also some apprehension about the availability of those masks for healthcare workers, if everybody should start wearing masks. But, the economics part of it is suggesting that, if we prevent the infections, if we flatten the curve, then that's, better in the long term and the economic impact will be shorter. So in terms of masks, there are different kinds of masks. I'm going to try and just show you what I mean. Can you see that at all?
Yep, can see it. So while you're showing us the different types of masks, some people are worried that the cloth face mask is not sufficient enough. What are you going to say about that? Then you go ahead.
Say that again, please.
Some people are worried that the cloth face mask is not sufficient enough to protect them or whatever.
Well, the thing is, I think it's more of an all or none thing rather than, so is it better for you to have absolutely nothing, or is it better for you to have something?
Right.
So that's it. But I was just going to take you through the different kind of face masks. So, there are different type of face masks. So you have the surgical mask, which is the one that is supposed to be reserved for healthcare workers. Now, this is something that a lot of us as doctors, nurses, hospital workers, healthcare workers would have been used to. So that's the surgical mask. But then there is also, and that's how it is worn, but then there is also the N95 mask, okay? And that is, again, reserved for healthcare settings. And there are differences between both of them. And then you were on about the, homemade mask, which the CDC has now recommended that, people should wear. And if you go on their website, it gives even how to make the mask. So you have the homemade mask, and they recommend that it should be made with double material and all of that. But there's this article, because there's been a lot of contention about, are they useful, are they not useful, are they useful, are they not useful? In a study that was done and published in this journal, the PMC journal, it says that when they compared it, they found that all masks actually provided some form of protection against transmission by reducing exposure during all types of activities. But the degree of protection varied by age, so to a lesser extent in children and more for adults. But the FFP2 mask, which is the same as the N95 in the US, it provided adults about 50 times as much protection as homemade masks and 25 times as much protection as surgical masks. But you've got to think about it in terms of the places where, my colleague was saying last week, Dr. OJ, that if you were in a healthcare setting as a doctor and you had aerosol generating procedures that can, release this virus in high amounts, that's where the N95 mask, the FFP2 mask, that's where they are most needed, because you have a high viral load being shed at that time because of the procedure that is being done. So that's not, that's slightly different from when you are in a supermarket and somebody is asymptomatic or just talking, for instance, which is why, it's not this kind of mask that you have in the general population. Does that make any sense at all?
Sure. You made a lot of contribution. Thank you so much. We're going to come back to you. Just hang on there. We're going to come back to you. We'll continue from that line of discussion. Can you return the share button to me? Thank you so much. We're going to come back to you because there's a lot to talk about face masks, how people wear it, how people are going to take care of it. You're going to wrap up those things today. Care of face masks, how you handle it. Are people going to wash it? Because I mean, is it reusable? Is it those questions? They're going to come back to you. But before we go there, the pediatric population, they can't wear face masks. Let me just show you just a quick peep of what I mean. See these little kids? They're very innocent. I'll show you that. These little kids, can you all see my screen?
Yep.
Yeah, they're very innocent. They don't know nothing. And many of us are doctors. They are their parents. We're working. They come back home. They hug you as a doctor. And are they immune to it? Dr. Emod, you're a pediatrician. Not only a pediatrician, you're a pediatric surgeon. You should be able to weigh on this. What's your thought process?
Yeah, hi. So thank you, Edward. Thanks for having me on this platform. It's really good to be here. So when it comes to COVID-19 and the pediatric population, there's a lot of differences. Permit me to just use this opportunity to share my slide with you to run through a summary of the unique features of children with regards to COVID, if that's all right. Okay.
So while you do that, I want to remind the audience that you're still on Doctors Conference Live. We were sharing a lot of health information so that you can take precaution and make sure that this virus doesn't come to you. We have 40 more minutes to go, so we have enough time to go around everybody, and we're going to take a lot of questions. Questions are coming in from all our feeds. We're going to take questions today. Thank you. Go ahead, Dr. Emod Victor. Okay,
so very briefly, I'll just look at COVID-19, the peculiarities and considerations in children. Looking at just trying to give you a summary of the different aspects of this disease and how they relate to children specifically. As an introduction, basically, just a reminder, children are not small adults. This is one of probably the most favorite phrases of pediatric surgeons and pediatricians worldwide, just to remind people that these children are unique. They are not just miniature adults. They're people of their own. And with regards to COVID, they've once again shown that they're different. And we'll see that as I go through. Looking at disease occurrence, just as a cover, children of all ages can get COVID-19, irrespective of age, even newborns, even if they appear to be less commonly affected than adults. To date, we've had about up to 50 cases of newborns with COVID-19 that have been reported. And the review of literature from all over the world, there was recently a systematic review that looked at about 45 papers on COVID-19 in children. And the data seems to be consistent that children just make up about 1 to 5% of diagnosed cases worldwide. In some countries as low as 1%, 1.7, like that, vary. And over half of these patients are within 10 to 18 years, and 1/3 occurring in late adolescence. So the other thing to look at is transmission, which is also very unique. Now, the community transmission, which Dr. Theophilus talked about, is very well established in children. They can't get it from droplets and transmission from person to person. But there are some unique circumstances that children are in, which adults are not, which makes them also more susceptible in terms of other routes of transmission. One of such is in utero transmission or vertical transmission, which is basically transmission from the mother to the child while in the womb. And as it is now, evidence suggests that in utero transmission appears to be very unlikely because from a lot of studies that have been done, there's been no detection of the virus in cord blood, that's the umbilical cord, in amniotic fluid or in placenta. There was a study that had about 26 pregnant women who were positive, and post-delivery they had these samples taken, and there was no viral culture. So it appears that for newborns who are infected early, it probably is due to postnatal exposure. It's the other route of transmission which is peculiar to children is breast milk. And thankfully, as of today, there is no known transmission via breast milk. For patients who have had COVID-19 positive patients who have had their breast milk tested, there's been no virus found. So in terms of transmission via breast milk, seems to be likely, but it's important to state that droplet transmission can still occur during the process of breastfeeding. So as the mother feeds the child, she could, infect the child from, secretions from her airways and mouth. So, but the overall recommendation is that breastfeeding should still be encouraged because, of course, the benefits outweigh the risk. Breast milk is known to contain a lot of immunoglobulins that would help the child's immunity. In terms of clinical manifestations, the children are also kind of different. The commonest symptoms we know, fever and cough, only appear to occur in just over half of symptomatic patients. Various studies from different parts of the world, data is consistent, ranging between 45 to 55% of children have cough and fever. So you have things like runny nose and sore throat being common, also occurring about 30 to 40%. And then vomiting, diarrhea, and abdominal pain can occur in up to 10%. And in some cases, it's the only symptom. So it means that these children present with a varied, very wide variety of presentations, atypical from those of the adults. So overall, what is very clear is that these children seem to have more of mild illness than the adult counterparts. In one study from China, over 90% were asymptomatic or just had mild or moderate symptoms. In the US, for example, as of today, the children just make up about 1% of hospitalizations for patients with COVID-19. And in fact, studies from China are also suggesting that as high as 16% of children may be completely asymptomatic despite having the virus. And this is very important, especially as Theophilus mentioned, in terms of person-to-person transmission, because the child could be very healthy, no symptom at all, yet very, very infective. When we're discussing adults, we talk about comorbidities or underlying health conditions that predispose adults to having severe disease, like being old age with diabetes and other long-term medical conditions. In children, that also appears to be the case. But so far, the few conditions that seem to be common are chronic lung conditions like asthma, cardiovascular diseases like congenital heart defect or birth defects when there are structural defects with the heart, or patients who are on immunosuppression. For example, patients who are undergoing cancer therapy, patients who have inflammatory bowel diseases, they seem to be at risk of having more severe diseases. Although this again is not too clear, because there's a study from Italy that had about 3 patients, COVID positive patients, post-transplant who were on immunosuppressive therapy, and they only had mild disease. So it's still very unclear the role of underlying medical conditions for children. But one thing so far has been consistent with the data, that children less than 1 year seem to be at higher risk of having more severe disease compared to their older counterparts. And then when you come talk about death rates globally, just a handful of reports. Thankfully, I would say the leaders of tomorrow are still safe from this virus as of today.
Wow.
Okay, some few things. In terms of laboratory findings, still different. The low lymphocyte defined in adults are not common in children. The inflammatory markers that are raised are also very mildly raised in children. And then there's higher rate of false negative tests. This is also very important with community transmission, such that studies have shown that only about 60% of children are positive even after both oral and nasal swabs. So you could have a child asymptomatic or symptomatic, you have a swab and it's negative, yet the child has the virus. Reasons are not too clear. Wow. Radiologic features to chest x-rays and CT scans are often normal. Last week, Omar talked about some findings on the x-rays and CTs. Those features are sometimes not present in children, even when they are very less severe. So these...
Go ahead.
Yeah, you want to say something? Yeah. So
we're going to get back to the chest symptoms, we're going to merge the clinical management,
Yeah.
the pathology, the children finding, and everything. We're going to merge it now. Dr. OJ, can you take it? I know pediatric is not the same thing. Pediatric are not small adults, like you said. They are quite different. They are very unique on their own. The audience are very, eager to understand more. This discussion will continue. Next week, we're going to continue, talking about the same talking points, what we can do to prevent it. Dr. OJ, in adults, what do we see? Like Ms. Rina had it. What is the classical finding? You've talked about it last week, so I don't want us to repeat ourselves last week. We're just going to go straight to what other unique things do you want to tell us this time around? Dr. OJ, over to you.
Oh, okay. Last week, I think we spoke a lot about the features that we see in COVID-19 and how it differs from persons to persons, especially the adults. And I think last week I talked about the fact that adults who have comorbidities are particularly at high risk. Okay, those who have heart disease, especially diabetes and hypertension. Other conditions are asthma, COPD, and also in patients with cancers. Okay. But interestingly, I really wanted to highlight this week in response to some of the questions we got last week that social distancing is the way to go. Currently in New York City, we are recording at 2 to 3 weeks ago, we had about 50 to 100 cases per day admitted, but currently we're having 1 to 2 cases coming to the emergency room. So this is in 2 weeks. So this is to reiterate the fact that social distancing and isolation is the way to go. Now, concerning the mortality is coming down in the United States, very, very down. In New York City, yesterday, I think about 200 in the whole of New York State. So that's some good point to say that in a way, from what my colleague, Dr. Theophilus has spoken about, I think social distancing and the lockdown that's been instituted in most countries is the way to go. But I just wanted to say some things about about patient's management, because I know it differs from country to country. Okay, currently, I don't think we need a negative test, because when a patient comes to make a diagnosis with the nasopharyngeal swab, we talked about that during our last conversation. But I don't think we need a negative test to confirm that the patient is suitable to be discharged home, because I think it's a practice in most countries. What they do is that they test the patient before they wait till the patient is negative before they discharge the patient. Studies have shown that the virus could be in the system for more than 15 to 30 days. And this increases the utilization of healthcare facilities. So you admit a patient and you keep the patient for 30 days before discharge. So I think the current criteria or guidelines we're using right now to discharge patients are for patients who are asymptomatic, who come with symptoms and now they get better. So the patient who come with shortness of breath, and in 2 days, the patient is much better, those patients could be discharged home. So we don't need a negative test to discharge the patient. Patients could self-quarantine at home, because I think it's a practice in Nigeria where everybody who has coronavirus has been admitted into a facility and isolated. Because that, in this case, we might overburden the healthcare system. If patients who come with who are tested positive with coronavirus and have no symptom, I mean, they're not short of breath, they're not, I think because the major reason why we admit patients commonly here is when patients get short of breath. And one of the new, I think the pathologists may throw a little light on this. One of the new findings we noted in the last couple of weeks is that this virus causes microthrombi and makes patients prone to having pulmonary embolisms and deep venous thrombosis.
Dr. J, we're going to come back to you. Just hold on there, don't go anywhere. Dr. John Wadioku, let's see what you guys are finding in pathology. What are you guys saying post-mortem and also in live pathology specimens? What are you guys saying? You've heard everything about the pandemic, the prevention. What specifically, in few words, what are you guys saying?
Okay, can you hear me?
Yeah, I can hear you very well.
Okay, thank you so much for having me. It's a pleasure to be here. I'm happy to see all of you, see my friends and all that. I think I appreciate you guys. Yes, a lot have been said about this COVID-19. Yes, in pathology, there are some evidences that you see that you suspect and say this is actually COVID-19 positive patient. It's important to say at this point that COVID-19 is actually generally it runs a mild disease course, okay, and only about 20% will progress to have severe disease. If you notice from the trend, from what you see, most patients actually recover. Okay, so it depends largely on your immunity, on your individual immunity. But however, if you have some background illnesses like diabetes, hypertension, like has been mentioned, immunosuppressive illnesses, cancer, you can have a more severe form of this disease, and this can progress to death. Okay.
Have you guys done any post-mortem analysis? What are your findings on post-mortem specifically?
Yes. Before I go into that, it's important that you can also get to take samples from corpses, from dead patients, even before post-mortem. So if you're not sure of a particular case, you can actually take a swab from a dead body. You can take a swab, a nasopharyngeal swab, and send for test. You can decide to wait for the result of the test, or you can decide to go ahead to do a postmortem. So essentially, the organ of interest here is the lungs, okay, because this is a respiratory disease. It's essentially a respiratory disease. And the virus is such that it has its receptors with which it can attach to the receptors in the nasopharynx and then the type 2 pneumocytes. So when this virus attaches to these receptors, they get internalized, and then they use the host machinery to produce their own RNA, and then use the host enzymes to also produce its own proteins. So in the process of doing that, it destroys the cells. So essentially, it destroys the pneumocytes of the lungs. And then what we essentially see for patients that died from COVID-19, we see an inflammatory response that is similar to what we see in diffuse alveolar damage. So essentially, consistent findings in COVID-19 patients are the findings that we see in diffuse alveolar damage. So what happens here is that you see a lot of inflammation, predominantly lymphocytes. Lymphocytes are inflammatory cells that we see in viral infections. So for COVID-19 cases, we see lymphocytes, all right, in addition to damage of the epithelium. So we see, like has been mentioned, we see evidence of some thrombi. We call it platelet fibrin thrombi that are seen in these patients, because the lining of the respiratory tract is damaged. So there's endothelial damage. There's activation of the coagulation system. So there's formation of thrombi, microthrombi. These microthrombi are seen on the respiratory tract. So we can see them on small vessels. So these patients actually may, in going retrospectively, may benefit from maybe drugs like aspirin, which is also being tried. Okay, so there's formation of thrombi in these patients. There's inflammation. The pneumocytes also become atypical. I don't know if I can share some slides that I have here.
Yeah, just quickly, because Dr. Omar is going to tell us what they see on CT scan again quickly. Let's see if it correlates from what you guys, if you correlate to what you guys are seeing in pathology. Go ahead.
Okay. So this. I don't know whether you can see this. This is.
Yeah, just click on your share screen button.
Okay.
Share screen button. Just click on it.
Can you see me?
If it comes, we're going to see it. But if it doesn't come, it's technicalities, but you can just say it verbally.
Okay. So essentially what we see, can you see me?
No, when you click on your share screen button, it's going to pop up.
Okay. Seems like I'm having some technical issues.
All right, while we're looking for you to resolve the technical issues, Dr. Omo, are you ready for us to let us see what you guys are seeing in pathology, in radiology?
Okay, yes.
Dr. John, we're going to come back to you because it's important that we understand what are they saying in pathology. Is it an inflammatory process? Is it microthrombi? What is it particularly? We're going to come back to you quickly because we're trying to form a story. Yeah, go ahead, Dr. Omar. Share your screen.
Okay. Let me share my screen.
I think the share screen button is,
It's having some issues, I think.
yeah, it's having some issues. Dr. Ovi, are you ready for us? All these things that everybody has been saying, Dr. Theophilos, Dr. Francis, Dr. OJ, everybody has been talking about this pandemic. We have a patient that is just affected. Yeah, somebody's sharing his screen, Dr. Omar. Dr. Ovi, I'll get back to you. Let's hear from Dr. Omar. I think she's overcome her technical difficulties. While we're still waiting for her to get her technical difficulties sorted out.
Can you hear me?
Yeah, very well.
Okay, good. Thank you for having me on this platform. Okay, today I'm just going to talk about, corroborate the information that Dr. John Ifeanyi and Dr. OJ said about the microthrombi. So this disease initially was known as a pneumonia, which is a ventilation abnormality. But studies have shown, okay, these are some references from studies that show that it's actually a perfusion abnormality disease as well, affecting the lungs, but not only the lungs, because these ACE receptors, ACE2 receptors are also found in endothelial cells and also in other organs. Sorry, I have to confirm. Can you hear me?
Yeah, very well. We can hear you very well.
Okay. Okay, so it's also found in endothelial cells, which make up which is part of blood vessels. So wherever there are blood vessels, it can actually, this disease can actually affect those organs as well. Okay, so I'm going to show some images in particular about a case report done in New Jersey on an 84-year-old man who had COVID-19, and he had multiple areas of thrombi in different organs. So I will just, okay, can we see this?
Yes, very well. Go ahead.
Okay, good. So the images are at the top. Okay, let me try to annotate now. So I could. Okay.
You're trying to show us microthrombi. For those that are not core medical people, microthrombi means blood clots, tiny, tiny blood clots. Go ahead. We're listening to you.
Okay. Okay, just the image is annotated just in case I can't get my mouse to work right now. Okay, so the images above actually showed what I talked about last week, the ground glass opacification and the consolidation. But the images below, because before now, the only imaging that was done, that was advised, is a non-contrast CT. So just check the lungs, but not the blood vessels. So they must have missed a lot of pulmonary embolisms in previous patients who had COVID. So recently, it's now advocated that CT pulmonary angiography should be done. And that's actually what will show these blue arrows that we're seeing here. They are actually the thrombi, the embolus within the main pulmonary vessels. So the contrast, which is the whiteness within the vessels, is actually being impeded, so to speak, by these gray areas, which is the thrombi. So this patient, this is one of the evidence that this patient had a coagulopathy, which is known now as part of the pathogenesis of COVID. So these are other images from the same patient, okay? That's the aorta, this white structure in the midline, and that blue arrow is actually pointing to another gray area within the arch of the aorta. So that's actually an embolus as well. And
Dr. Moore, it looks as if you're
on the right. Yeah.
Dr. Ma, can you hear me? So from the evolving consensus, from the evolving consensus, you're saying that these theories are evolving, right? They're not definitive. You are thinking that the patients are clotting all over everywhere. Is that what you're saying?
Yes, it is actually an evolving process. This patient, for example, has not had any history of coagulopathy before now. No, he's not in a hypercoagulable state. Right. He has no atrial fibrillation before now. So these are other risk factors for multiple thromboembolic disease in a patient. But he didn't have any of these risk factors. He had COVID-19. Okay. Unfortunately, he actually died after all the efforts to try to save him. So this same patient, like I'm saying here, this is the abdominal CT. The blue arrow here, it's pointing to the upper pole of the left kidney. It shows a gray area again. It's wedge-shaped hypodensity. That's like a gray area within the kidney. And that's the description of an infarct. So he had a renal infarct, which was possibly secondary to embolus within the renal artery. That's
so,
the same patient.
Dr. Omo, I know you're a specialist. People are watching. They want to know these technical terms. I'll be breaking it down for them. What it means is that area that she just showed, can you go back to that last picture? The blood supply to that particular area has been blocked. And because the blood supply to that particular area has been blocked, the area it's dying. That's what she means by infarct. Go ahead.
Exactly, it's actually dead. It's not being supplied. Okay, so now this is the last image of this same patient. Okay, the image A actually shows the pathology. The arrow is pointing. This is an angiogram where you inject a dye, okay, to outline the vessels. These are the vessels of the cerebral vessels, the posterior circulation. Okay, so this clot was actually lodged at the distal aspect of the basilar artery. Wow. We're actually supposed to see the entire branches of that posterior circulation. The B image shows it, so we can see the spider web appearance of the branches. On the image A, there was a clot. That's why it couldn't actually outline it. And then the patient was given a lytic agent, which allowed the vessels to show.
There's a lot to say on this topic.
On the image B.
There's a lot to. Go ahead. There's a lot to say on this topic, okay. Doctor.
So, right now, the recommendation for diagnostic and therapeutic management of COVID-19 patients. Yeah. Can you hear me?
Yes, very well. We can hear you very, very well. You said the recommendation. Go ahead. Just finish the last statement, the recommendation.
Okay, yes, this is the last statement I'm going to make now. So the recommendation for patients with COVID-19 for diagnostic and therapeutic management, which is actually going to be based on the patient's symptoms and the risk that the risk profile of this patient should include prophylactic dose heparin, chest CT, as well as CT pulmonary angiography, which was initially not done for this patient, as well as routine D-dimer testing.
Beautiful.
So this would actually help this patient.
Beautiful.
Thank you very much.
Thank you so much. That was so brilliant. Dr. Nwadioku, you're a pathologist. We've asked you this in one statement or in two statements. Does it corroborate with what the radiologists are seeing in one or two statements? So we can move over to other presenters.
Yes, it does. Can you hear me?
Yeah, very well.
Yes, it's important to say that the thrombin formation is a sequel of the inflammation. Okay, so there's a correlation between inflammation and coagulation. So the coagulation. Hello.
What the audience want to know now is are you people saying that the evolving pathologies is both inflammatory and microthrombi?
Yes. Evidence has shown. Yes.
Beautiful.
Yes.
Beautiful. All right, thank you so much, everyone, for watching. We still have a couple of minutes to go, about 15 minutes to wrap up. Dr. Francis, Dr. OJ has an emergency, so he had to leave for the management. So we'll get 3 or 4 statements from you, newer treatments. Specifically, a lot of people have taken herbs. I know if I ask Miss Rena Roberts, did you take herbs? Let's hear from her before you go. Did you take herbs? Did you take any tea?
Yes, sir, definitely.
Did you think it worked?
Yes.
So right here, we're medical personnel. We cannot say, oh, it worked or it doesn't work. We're just listening from your own experience. That's not our recommendation, though. We just want to get it clear to everybody. What specific did you take? And why did you think it worked?
I took, first off, I had me some Tylenol I took for the pain because I started to experience severe headaches. And then for the tingling in my throat, I took some cough syrup. And then I went to having ginger tea. I will blend the ginger and the garlic and lemon and with some lime. But then later on, I tried to cut back because I remember when I was leaving the hospital, I was told that I was a little bit anemic. So I cut back on the lime a little bit. But for the most part, the ginger, the garlic, those were the main things. And I also used I boiled the onions and whatever leaves, the pineapple, feeling like I was instructed by my sister who had this virus before, to one of my sisters. And then I used those things, I boiled them, and morning and evening I will put some Temple of Heaven in the water and just sit over that bucket, over that tub, and for like 15 to 20 minutes, cover myself with the blanket or something and heat up, taking some heat, and steam myself up. And after that, I will feel refreshed. I feel different. I feel good.
In summary, you are trying to say that you used a lot of herbs, what we call mixtures or whatever. Dr. Francis, why is it that those mixtures and herbs that people take back in Africa, the Western medicine is not embracing it per se, from the research perspective, before we go to the economic impact?
Simply because, thank you so very much. Thank you again for having me. Simply because what she has just shared with us is what they call anecdotal evidence. It simply means that, yes, there's a possibility that it works or it worked, but it's not been tested. There's no scientific evidence. There's no data that kind of supports its efficacy again and its safety. We're very concerned with safety and efficacy. So yeah, most of the herbs that is used back in some of these countries could produce some results. And then it might be believed that the results are as a result, the treatments, it might be believed that the person is recovering because of the herbs. But the question is, it might be believed they are anecdotal. It means that it has not been tested. Clinical trials are a systematic and a scientific way of accruing data that, that supports that an agent has a therapeutic effect that can be used. So the herbs that are used in Africa are not really embraced in the Western world because it has not passed through that process of testing. It has to pass through a process of testing, and it has to have data that backs up, those evidence. And it has to be safe before it's confirmed definitively to be a treatment strategy. So that's the answer to the question. Those herbs have not been tested, and until they are tested, and until it's proven that they are helpful, it cannot be released.
Right. There's a question we have, Dr. Egbe. Before Dr. Ovia, we talk about, let's see how we can scroll to that questions. Questions are just coming in. I think you sent in that question from one of your feeds. Is there recurrent COVID-19 infection after discharge? Dr. Egbe, can you weigh in on that?
Did you want me to say something about that?
Yeah.
Well, I think the jury is out as far as I'm aware. I'm sure the rest of my panelists may be able to say more on this. The jury is still out about whether there's reinfection or not. As we know, this is a rapidly evolving scenario. Everybody's learning, and there are lots of research is being done. There's some evidence to suggest that there could be reinfection, but it's not very clear yet. It's all still being researched.
Wow.
But I don't know whether the rest of my panelists might have something else to say about that.
Right. We'll get back to that. While Dr. Ovie is a medical economist, everybody's inside, everybody's angry. I'm angry. Dr. Theophilus is angry. Dr. Joseph hasn't said anything since morning. Everybody's just angry. We're all stuck indoors. What is going on? What is going on?
Thank you very much, Edward, and the other panelists. Can you guys hear me?
Yeah, we can hear you.
Thank you for the opportunity to talk. For the sake of time, I am going to talk more about health economics and just talking about global economics. Many of us, as we've raised very salient points, I want to try to address some of these issues people have brought before us. One, looking at one of the benefits of remdesivir, which is the new drug that has been given emergency approval, what that means for health economists. So remdesivir has a 31% rate than the current standard of care, and it helps reduce hospital admission by 3 days. People wonder, what does this mean? How does this help me? The average cost of ICU hospitalization in the United States is about $25,000. As economists, we look more at money. We look at how our scarce resources are utilized. So $20,000 for a 1-day admission. Let us assume currently we have about 1 million people infected. We have about 20% of those seriously admitted, with the healthcare system almost crumbling. So if we have, let's say we have 10,000 people who require ICU, and we take 3 days from it, 3 days times 10,000, we're talking of $25,000 times 10,000 people. You see that huge benefit. So this is how health economics, this is how we think. Look at flattening of the curve again. What does this mean for healthcare system? If you remember, with the rapid increase in cases in New York, we saw that the healthcare system crumbled. They had to bring in the ship, they had to build the Javik Center. What were they trying to do? They were trying to increase capacity so they could accommodate the people that are coming with high infectious rates. So what healthcare system and the CDC, what they did flattening the curve, they tried to reduce the weight on the healthcare system. They try to expand capacity of the healthcare system so that it doesn't collapse. Flattening the curve, try to reduce the spread. It doesn't necessarily, according to what Dr. Fassi mentioned about 3 days ago, we are now working on moving towards a situation where we will try to improve herd immunity. Herd immunity where most people could have been exposed to the virus. One thing we've not talked about, and I want us to talk about it next week, is the benefit of having antibody tests, how that will improve or help what's happening in the economy. If you remember, most of us that came from ECBO, we all have kind of passive immunity already against Lassa virus. That's why you see most of us can function in areas of it because we didn't have PPPs with them. So let me try to wrap up with what Omar mentioned about using CT for treatment. Now, if we're going to use CT scan for the treatment of patients, how do we accommodate protecting patients? Because CT scan is an enclosure where we expose patients, and if we test that patient is positive, we need to clean the CT scan. If hospital has, for example, an hospital has like 2 CT scans, how would they share the CT scans to use by all the patients coming into the hospital? They will have to devise a way that they will protect others from coming in. That will equally increase the cost of hospital management. So we're still trying to strike a balance here between what will be good for us and what will be horrible for us. Then finally, let me go to the last question. Nigerians now have been locked at home for more than 1.5 months. But this is going to have a huge economic impact on the country. Studies have showed that about 46% of Nigeria, they live by paycheck to paycheck. When I mean paycheck to paycheck, we have a huge bulk of the population who get their money daily. They don't work for any standard organization. The carpenter just go, does job, comes back. The tailor just go, does a job and come back. And that's how they get their resources. But with locking everybody at home now, it's not feasible because we are going to increase the poverty rate. Look at the global economic and the global poverty index. It's in the last 10 years, we've tried to reduce poverty level. This uses measures. I don't want to go into details how we calculate these measures, but there's let me explain it to the very common. We try to evaluate number of people in the population who live under $1.9 a day. Let us look at the Nigerian minimum wage. Nigerian minimum wage was also increased to 30,000 naira. 30,000 naira is less than $100. So if we spread that into number of days, that tells you the number of Nigerians living under $1.9. And with this current stay at home, in the last month, most people are not making any money anymore. And we don't have this safety net done in Nigeria like it's done in a civilized country. In the United States, most families are giving $1,200 for the adult, $500 for the children. That will help to reduce the hunger rate. That we never had such measures in Nigeria. So I think one of the best approach to wrap up, or one of the best approach I would suggest is to let people go to work. Follow the new NCDC guide, which recommends reducing interstate travels. That way we can manage the spread of the virus within states. We use face mask. Allow everybody, they should put policies to make sure everybody uses face masks. Then for our hospital capacity in Nigeria, we don't even have a system. According to the WHO, we have 0.5 hospital beds per 1,000 people.
Wow,
that is ridiculous. And if we look at the number of people being infected today, the rate is almost like 3.5% because we've barely tested about 11,000 people. Having about 12,000, we've barely tested about 11,000 people. We have almost 3,000 positive.
wow.
The incidence rate in the last 2 days, the incidence rate in Kano has increased by almost 100%. That is because we don't even have the facility. Then how do we cater for these people? So there are a lot of challenges we have to see how we can navigate.
There's a lot to say about this in the economic world. There's a lot to say. Quickly, everybody has two minutes to round up. Dr. Theophilus, what is your takeaway point? Just 2 minutes, in 2 minutes, a few statements. You unmute yourself.
Hey guys, I want to emphasize on social distancing, okay? Because I know there are a lot of things I wanted to say, but we can carry it over to the next time we meet
we're meeting same time, same place next week Sunday. Don't miss it.
Okay, but I want to conclude with 4 lessons that we can learn from the 1918 Spanish flu. All right, so some experts have gone to check out this, that flu that happened about 100 years ago, and there are 4 key things we can take away. Now, the first one is that as devastating as this COVID-19 is right now, the Spanish 18, the 1918 Spanish flu is the worst in history. It's the worst pandemic in history. It claimed 50 million people. 50 million people died. And it had 3 waves of the virus from 1918 and 1919. They had 3 waves. Among the 50 million people that died from that pandemic, 675,000 were Americans. So if you look at what COVID-19 is today, it's not even close yet. And just for those who don't know, there were 3 other pandemics that happened between 1918 and now. In 1957, there was a flu pandemic. In 1968, there was a flu pandemic. And in 2009, there was another flu pandemic. So all of those 3 pandemics, they claimed 3 million people worldwide. But it's still not close compared to the 1918 Spanish flu. So that's just for us to know that no matter how devastating this one is, we are still lucky to be alive at this time and not in that time when those people died. 50 million people died. The second takeaway from the 1918 Spanish flu is that there are key differences between 1918 and COVID-19. The first key difference that those people that lived in 1918 did not even know it was a virus. And it's understandable. They didn't have microscopes as we have now to detect viruses. As a matter of fact, viruses were not discovered until the 1930s.
Wow, wow, wow.
So they were just living, all they knew about that virus or about that pandemic was that at least it was spreading from people to people. The people were coughing, they were sneezing, they were getting it anyways, but they did not know what it was. So it was just killing them like flies.
So you're saying we're lucky
but
to
luckily for us, luckily for us, we have microscopes to know that this is a virus one, and then we can test. So there was no testing then. Now we can test. All right. The third takeaway from that pandemic is that despite the differences that exist, there were still some key striking parallels among this COVID-19 and 1918. The first striking parallel is that in both instances, they didn't have vaccine, all right, and treatment. Anyways, right now we are beginning to do, like Dr. Francis said, we are having clinical trials of some drugs that are showing, good prospects, and also vaccines are being tested. But as it is right now, we can't say this is the treatment for COVID-19. So both instances, the parallel is that there's no treatment, there is no vaccine. Another striking parallel is that there is this overriding fear that our health system will crack. And that is true. Okay. We saw it in Italy, we saw it in Spain. Right now, they are having overwhelming, cases, and that really affected the health system. Nigeria now is a case for concern. If you look at Nigeria in West Africa, a city in Nigeria, Kano, is a case of concern because the people are not very well informed, and then they are not maintaining social distancing. The last takeaway I want to say that would make me just for me to emphasize this issue of social distancing is that in both pandemics, the most effective response is social distancing. In 1918, they didn't call it social distancing, but it meant the same thing. They call it crowding control. That was the name they called it in 1918. And crowding control, it's the same thing as social distancing. So what it means is that you have to avoid people if you don't want to catch coronavirus, right? So people we must keep emphasizing social distancing to be able to flatten the curve.
Quickly, wow, that was very brilliant presentation. Quickly, we go next to the next person. 2 minutes, just 2 minutes round up, 2 minutes round up. Dr. Francis, are we looking at herd immunity?
Thank you again for having me. Yes, we are looking at herd immunity, and what I would like to say is in response to what Dr. Tio said. There's been a lot of changes way back in 1918 to where we are right now. Billions of dollars have been spent, and there are well over 200 trials in registries out there. We're very hopeful that we're going to get or develop a vaccine in treating COVID-19. And I also believe strongly, based on experimental data that we have, that there will likely be a treatment for COVID-19. Again, I don't know when, I don't know, what duration we expect to have that, but we believe strongly, given the infrastructure that we have, the scientific innovations, the technology and advancement in medicine.
Wow.
Yes, it's exciting. It's interesting to know that we're looking towards something for the COVID-19, of course, subsequent, pandemics out there in the future.
That's beautiful. Dr. Emodi, you're a pediatrician. The mothers are worried. Kids cannot talk. What else do you want to tell them?
Okay, so basically, the emphasis here is about prevention of transmission. And the unique things to children we need to look at as one, mother-to-child transmission when we talk of breastfeeding, which I mentioned before. So mothers who are infective or who have cough, who are worried about symptoms, need to put on a face mask, wash their hands properly when they're breastfeeding, but it should not stop breastfeeding. That's the current recommendation. The other thing we need to understand is when you talk about social distancing, children don't know what that means. I mean, it means nothing to them. As far as they're concerned, if you don't allow them to play, they're angry. So we need to, we as adults, their parents, guardians, have to take responsibility of keeping them away from places where they would have to socialize. So playgrounds, play dates, as much as possible, should be avoided. And when it's impossible to keep them away from crowds, then of course the recommendation about use of face masks comes in handy. And the CDC is saying, yes, cloth face masks, like you may mention, are fine, are okay for children. But the caveat is that they should be at least above 2 years of age, because less than that, there is a concern for suffocation. So, but yeah.
Go ahead, wrap up.
So beyond that, it's that's a concern. And then the use of hand sanitizers too, that's also something people are worried about for children. People are talking about safety. Children lick their hands, they put their hands in their mouth or without any caution. Yes, so the recommendation now is that yes, hand sanitizers are safe for children. And if for any reason the child licks his or her fingers, as long as the hands are dry, there is no concern. Yeah, so if for children who are less than 6-7 years, if you must use hand sanitizer, then you have to supervise it and make sure that they scrub properly and it's dry. One last thing about transmission, which is very important, is from patient to doctor or nurses. Now,
yeah, we're going to talk about microbial transmission the next time.
Okay, that's fine. That's fine.
Yeah,
so basically,
coming in for that.
Okay, so basically, we need to keep these children. They are our responsibility, and they do not understand social distancing. You have to implement it for them. When it comes to face masks, just one last thing. Things that could, because some children also are not comfortable covering their nose and mouth, and they don't understand why you're doing that. They see it as punishment. And one recommendation I would say is having face masks that have some of their favorite cartoon characters. Say for the boys, if you have a face mask that has a PJ mask, and for the girls, Sophia the First, I'm sure they'll be happy to wear a face mask of Spider-Man all day without any complaint. So that's what you can look at.
I know all the specialists in this panel, they have so much to say. Dr. Way, are we in this for life? Is it going to end? Is it going to end? Are we in this for life? Something tells me this is our new lifestyle.
Well, I think that things are going to change, definitely. But I think that the current situation is not going to remain as intense, if you like, as it is. We can already see that there are some parts of the world, in Asia, for instance, they've been able to reopen the economy, they've been able to go back to work, go back to school, albeit with measures put in place, like social distancing and face masks and other measures have become the new norm. So yes, it's unlikely that things will go back to the way they were before, but again, it's unlikely that we'll be on lockdown forever. It's unlikely that we'll see thousands dying every day forever. A cure, I suspect that very soon there will be some green light in terms of a vaccine.
Talking about green light.
I'm optimistic that there will be some, the research is going on. We bring out some positive results very soon. I just wanted to say something before I go.
Quickly.
I know last time when I spoke, I spoke about how that the N95 mask was superior to the surgical mask, which was superior to the homemade mask. And I'm sure a lot of people were wondering why you don't give everybody an N95 mask. Well, the first thing, there are key differences, but one of the things to say is that, as one of my colleagues mentioned earlier, the data what we are saying now has come from previous outbreaks or previous pandemics. There's been no head-to-head trial as of yet to compare the transmission of COVID-19, the effectiveness of protection of the different masks. So we are extrapolating from the past. It may be that things are slightly different. Having said that, the other thing I was going to say was that the N95 mask, which is used in the hospital, if there's no aerosol generating procedure like intubation and all of that, then there is no real superiority between that and the surgical mask. And don't forget, the N95 mask has to be specially fitted. So you can't fit everybody in the population with an N95 mask, neither can everybody in the population get a surgical mask. For the handmade mask, the CDC have put, very, very good recommendations on how they should be made. They can be washed and they should be taken care of carefully. You should wash your hands still and all of that. But, they are better than nothing.
Thank you so much. Thank you, everybody. We're going to hear what lasts from our patients live after you are free. How does it feel like, Rainer? before she speaks, because we're running up in 1 minute, she's going to speak almost last. There are 2 doctors or 3 doctors that did not even say anything. They are very, the consultant obstetrician, we're going to come back. Next week, we've just succeeded in introducing this topic last week and this week. These are all just referral introduction. We're now going to go narrow down to specifics, non-pharmacological intervention. That's what we're going to talk about. So we're going to go into detail next week: hand washing, sanitizers, social distance. What does it mean? Measurement. We're not going to discuss this core stuff that we're discussing. We're just going to go to the children. What do we do to this? What do we do and that? We're also going to look at other advanced societies that are actually implementing one non-pharmaceutical intervention or another. We're also going to look at researches concerning non-pharmaceutical intervention. So these 2 weeks has been introduction so that everybody will have a feel of what it is. Same time, same station, same place next week. Be with us. Dr. Theophilus is also going to talk about what's going on in Canada. Everybody is going to talk about the non-pharmacological intervention. Ms. Rina, live after COVID-19 in 1 minute.
Thank you. I feel very good. I'm just a little bit of not afraid. I'm terrified a little bit on going back to work because I started work on Wednesday, and I am just worried about reinfection. That's all. But I'm doing what I have to do, taking care of myself, and like I said earlier, I feel excellent.
Thank you so much. This panelist has been so wonderful. Specialists, experts, just name it. Medical personnel who have dedicated their time. We say thank you so much. They've dedicated 1 hour, 30 minutes of their time to educate the masses. This is our give back to the society so that history will hold us and say, yes, when the world has a problem, some people came out to educate us so that we do not take fear over facts. That's the main essence of this whole thing. Someone called by name Joe Morgan dedicated a song to our program and said we should play. We'll use that as our running up note. Thank you, panelists. Thank you, everybody, as we play Joe Morgan to round up the run.
I cannot live like this.
Oh, Joe Morgan. Just give me a second. There's just a little bit of technical glitch. We're going to sort it out in 1 second. We'll sort it out in 1 second. Just 1 second. We'll sort it out in 1 second, and we have sorted it out. Returning back to Joe Morgan, as he gives us that we cannot live like this in this period of COVID-19.
I cannot live like this. I cannot live like this. I cannot live like this no more. You cannot shake your friends. You cannot hug your children. You cannot hug your mother, hug your wife, or take them out. Anywhere you go, you cover your nose, cover your mouth, or cover your face. I don't know what's going on. Life is a scary ship. Oh yeah. Or anywhere. Or anywhere. When you're already or radio. Or radio. Or radio. Yes. Or radio. When you're already or radio. Or radio. Or radio. Used to be so lovely. You sit down with your friends and have a bottle of beer together. Oh, but now times have changed. It's changed for the worst. I'm so scared now. Anywhere you go, you're gonna cover your nose, cover your mouth, wash your hands, wash your face, and wash your clothes. Yo, Orenio, Onyabuene, Orenio, Orenio, Onyabuene, Orenio, 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 Orenio.
Thank you so much. See you same time, same station next time.